Namaskar. On behalf of Raipur Obstetric Gynec Society, Society of Fetal Medicine, and Society of Stillbirth, I invite all of you to this meeting that I hope will solve some of the problems that we clinicians are facing. Just 2 days back, on Sunday, a patient who had absolutely normal Dopplers and she didn't know her exact dates. She came to me and when I examined her, she came at 9 o'clock. So the heartbeat had stopped. We tried to deliver her normally. She didn't deliver. And today we had to operate on a dead fetus, which was 1600 grams macerated, but very high. And it was a placenta that was totally white. So stillbirths happen, and it is such a tragedy for the patient, for the family, and for the doctor. If there is anything that we can learn that will help us to prevent this, to have our children born and born healthy on time, it is something I think we all have to learn, and we are more than eager to learn. I thank Dr. Khurana sir for actually accepting my suggestion for this topic, that yes, this is what we will do. Very good. And as usual, he was, yes, absolutely fine. And he has arranged this great academic feast involving the Society of Stillbirth with us today. So I welcome all of you, and I hope you will listen carefully so that we can give better care to our mothers and their children. Thank you, sir. Over to you.
Well, a very warm welcome to everybody. And I now hand over to Dr. Tamkeen Khan to take over the proceedings for the entire evening. Thank you so much for joining us today, not only in your capacity as a member of our Society of Fetal Medicine, but also the Stillbirth Society of India. Thank you so much for being here. And my special welcome to Dr. Neelam Agarwal. So over to all of you.
So thank you so much, Dr. Ashok Khurana, members of our Raipur Obs and Gynae Society, and all those who have logged in today. Very good evening to all of you. And I must begin by thanking Dr. Ashok Khurana, first of all, for giving us this huge platform and very prestigious platform, and at the same time giving us a vision as well by asking us, you know, the topic that he had chosen, Stillbirth, a practitioner's guide. And we hope to conduct this and develop this into a complete module and conduct these webinars with as many societies as possible. And we begin today our program. Our society is just, you know, was launched in July this year. So it is very, very young, just 4.5 months old. And I hope more and more people, more of you will be joining us after you are introduced to it. It's my pleasure to introduce our president, Professor Neelam Agarwal. She's the president of the Stillbirth Society of India, and she's working at the prestigious Postgraduate Institute, Chandigarh. She has done a lot of work on stillbirths in collaboration with the WHO and also the International Stillbirth Alliance, especially in the field of stillbirth surveillance and bereavement care, and developing modules for Parents' Voice Initiative. So she'll be talking about the magnitude of the problem.
Thank you,
so
Dr.
Yeah,
thank you, Dr. Tamkeen. And good evening, everyone. On behalf of Stillbirth Society of India, first of all, I thank Dr. Ashok Khurana for giving our society, which is just not even an infant, just in the beginning stage, to give this platform for a wide outreach. So I'll be just talking about the magnitude of the problem. So I have just misplaced one of my slides, which shows that out of 2.6 million annual stillbirths globally, 96% are from the low middle income countries. And because of our sheer billions of people, number in sheer billions, India tops the chart of stillbirth in numbers, even though it's not the #1 country for stillbirth, but our numbers are the highest globally. But the irony is that stillbirths are most poorly recognized from the places where they actually are commonly occurring. So that is exactly what is happening in India. About a decade back in 2011, WHO had given us a small project to find out stillbirths in context of syphilis. At that time, when we tried finding out syphilis and stillbirths, that time we were surprised to know that there was no record of stillbirths and syphilis. So then we went back and saw that there is no record of stillbirth. Stillbirth was not recorded anywhere in any of the forms. And because of this non visibility of stillbirths, there was a mismatch of burden to action in India. So far, there has not been much action about the stillbirths. Just in the recent 2 years, ministry has also become sensitized to the stillbirths, and especially this is after the international awakening from 2011, when Lancet has brought out 3 consecutive series only on stillbirths. And after that, there has been a awakening internationally, especially for the low middle income countries, for prevention of the stillbirths, prevention of preventable stillbirths. So when there is so much of burden which is unseen, it keeps on increasing, and there is hardly any action because it's not seen. And this invisibility and confusions leads to the phrase out of sight, out of mind. That's why nobody bothers about stillbirths. And stillbirth protocols are usually very difficult to standardize because numbers are missing. There are not actual numbers where we should act upon, and definitions are very varied. They vary from 22 weeks to 28 weeks, but for comparison purposes and as a reference point, WHO definition of 28 weeks or 1 kg birth weight is being taken as a standard for the international comparison. And this is a mammoth task to make people sensitized about the stillbirth. And where are the stillbirths? So this is the latest 2020 report of United Nations Interagency Group for Neglected Tragedy, Global Burden of Stillbirths, where this is the world chart which shows the stillbirth. This red dots are the places where the stillbirths are the maximum. And what is the magnitude of stillbirths in India? If we go by this SRR system, doesn't give you much burden about the stillbirths, but this UNIGME report in 2020 has shown that they have reduced from 29.6 per 1,000 births to 13.9. And India Newborn Action Plan target is to have stillbirth rate by 2030 in a single digit, that is less than 10 per 1,000 total births. So in 2009, the recorded was 22 stillbirths per 1,000 births as per Lancet series. So what do we mean in real terms? How many stillbirths, how many births? So you can see from the figures that out of 74,000 births in India every day, 1,000 parents do not take a live newborn baby home. So this is the status of stillbirth surveillance in India, which was started in 2015, and that too courtesy WHO CRO. In the facility-based stillbirth surveillance, there are 17 centers. 7 are with Delhi Safdarjung Hospital, and 10 are with us in PGI. All of these are high burden, either tertiary institutes or the medical colleges, where we are doing the stillbirth surveillance to just see whether it is feasible to do stillbirth surveillance and what all is to be done. And these are the steps which we have taken from 2011 till date. Initially in 2011, stillbirth registry was originated to eliminate congenital syphilis, but then we saw there was no records. So it started with development of a facility-based stillbirth tool which was pre-tested in 5 hospitals, and then prospectively tested in 10 different hospitals, and then it continued into newborn birth defect database and BBD database. And this genesis of facility-based stillbirth surveillance was from PGI and in this thing with the WHO CRO. And then it was linked to CRO newborn birth defect database. And this is the simple stillbirth surveillance tool where all the data is there and cause is assigned according to the ICD-PM classification. And this was the operational guideline, which was also developed by us for establishing sentinel stillbirth surveillance system in the SEER region. So by our experience is now for the 5 years from 2015, we have had about 21,000 recorded, 22,000 stillbirths, giving us a rate of 37.4, which is high, but then this is because it is only facility based, and mostly facilities are referral facilities where high risk patients and after antenatal IUFD are being sent. That is why this much high. But are numbers enough? No, numbers are not enough, because by counting again and again and again, there will not be any solution. Suppose you have an underfed cow and you keep on putting her onto the scale every day, weighing every day will not help you unless you find out the problem. What is the problem for the animal not to gain weight, and then sort out that problem. So similarly, we have now enough numbers. We have seen about 22,000 stillbirths, but they will not be of any use until we do the stillbirth surveillance review and response. We review the each means some thematic stillbirths we review and take out the causes, what are the causes, and out of the causes which can be assigned by ICD-PM and also by patient provider perspective, then take out the solutions and make policies for preventable stillbirths, right? And then any mother whosoever is bereaved because of the stillbirth, does she get any care? No. We all know that in our busy labor rooms also, we go on the rounds, and the attitude of most of us is, okay, this is IUFD, okay, this will, anyways, she will deliver. Means she is not given due consideration even during labor and after labor. And so bereavement care is a big no in our setup so far, and we have to work in that area also. So we have a genuine need to sensitize each and every gynecologist as well as pediatrician as well as a general practitioner. Then only actual cause of stillbirth can be assigned and prevention can be planned. And like maternal mortality, each stillbirth must be investigated. Now let me ask every one of us, do we react for a stillbirth the way we do for maternal mortality? Mostly our answer will be, honest answer will be no. Because in somewhere in our heart of hearts, we have this idea that woman has a next chance to have a live baby. But this lost one is not the same. This lost baby will never come back. So accountability of each pregnancy should be there, whether it is ending with in a stillborn or a liveborn. So we must start stillbirth registry at each center to begin with, and then to start review and response. And simultaneously bereavement care to those who have not been able to take home a live baby. Thank you so much.
Thank you so much, Dr. Neelam, for giving us that overview and sensitizing all of us to the magnitude of the problem, and also that India is contributing to almost 50% of these stillbirths. And of course, two very important points that you made. I love that example of weighing the cow again and again. If you're not doing anything with the data and you're not taking proactive action, then it is all useless. So thank you so much, Dr. Neelam.
Thank you.
So now we move forward to the case-based discussion that we have, and we'll be taking some very important issues that are there related to stillbirths. Can I start sharing my screen? Yes. So the Stillbirth Society of India was started just about 4 months back, and I'll be sharing with the group the link to the Google form, and I invite all of you to be members of the society. And I'm singularly, fortunate to have a whole galaxy of learned people, academicians, and those who believe in action to be with me in the Stillbirth Society of India. And we have this small case, which is Stillbirth, a practitioner's guide. And I have some great panelists with me. Professor Reva Tripathi is currently working at HIMSR as professor and HOD, but she has previously done a lot of work on fetal medicine, diabetes especially, and has trained many people under her at MAMC. And she herself has been trained at Yale University and Stanford, USA. Professor Manjupuri, professor in Obs and Gynae. She has occupied various leadership roles, a great organizer and a team player, and somebody who's very passionate about applying QI principles for improving women's health. And recently she organized a great AOGD webinar on stillbirth bundle. Professor Nandita Kankar, we are so lucky to have a researcher par excellence who's working in the Department of Histopathology at PGI, and she has contributed many papers and books on perinatal pathology, and she's also part of the SBSI Perinatal Pathology Committee. Dr. Manisha Kumar, also from Lady Harding, established the DBT Nidan Kendra there, is also a fetal medicine expert and part of SBSI. I'm really thankful and lucky to have her. Dr. Aparna Sharma, working at the prestigious All-India Institute of Medical Sciences in the unit of fetal medicine, is also the pioneer of QI, working with WHO, and has trained and initiated many of us, including myself, in quality improvement. Dr. Bharti Sharma, the youngest, the most passionate, and most active of all of us, is working at PGI Chandigarh as a consultant with WHO on the Stillbirth Surveillance Project. So we have a very learned panel with us, and we begin with the case discussion. So the case goes like that Mrs. A 33-year-old lady who was a book primary gravida with 37 weeks pregnancy, reported to the obstetric triage at 9 p.m. with the complaint of decreased fetal movements for 2 days. She was seen by a resident who reviewed her antenatal records, found no high risk factor. Her ultrasound at 21 weeks showed a morphologically normal fetus. Examination, she was obese with a BMI of 40. Her vitals were normal. The per abdomen examination showed that she was 34 weeks in fundal height, fetal heart was regular, and uterus was relaxed. The resident used a Doppler to listen to the fetal heart, reassured her, and advised her to come back with a Manning score next morning. So I would request Dr. Aparna Sharma to answer this question. Do you think this was the right course of action that was taken by the resident, and how would you manage such a case?
Yeah, hi, ma'am, and very good evening to all of you. So regarding this particular case, so yes, I think the first thing that when a lady comes to us with reduced fetal movements, so I think the first thing is that the resident looked at the fetal cardiac activity. Yes, I mean, that's a good thing. But again, it is always important that a note is made of whether this patient is a high-risk patient or not. And also some form of fetal testing should have been done and not been advised next day morning. So that is something that remains to be seen. And I think all of us face this situation where, patient complained, not being, and next thing, the patient turns up with a intrauterine fetal death. So yes, I mean, I would definitely look into the fetal cardiac activity, evaluate the risk factors which are present with a record review of, what are the risk factors in these patients. And I would offer fetal testing in terms of either a non-stress test and a biophysical profile. So that is what I would do in such a case.
Okay, thank you so much. So what is the significance of fetal movement counting in assessment of fetal well-being, according to the current evidence, especially in the light of AFFIRM study?
Right. So I think it's not just the AFFIRM study, but even before that, there has been controversial evidence on reduced fetal movement. So, various guidelines have, although the evidence does not repeatedly to say that there is no effect, we repeatedly continue to use this thing. So the point being that it's inexpensive and one easy to access measure for fetal well-being. The AFFIRM study, yes, they did. They actually had groups where they were advised interventions based on the reduced fetal movement care package, but they saw that they did not reduce the risk of stillbirths. Now, there are certain issues with this trial also that really needs to be seen, because it was surprising that there was actually no effect between the two groups. And it has also been suggested that, something called the Hawthorne effect, where because the controlled people know that they are in control, so they also seem to be more aware of their fetal movement. So yes, of course, there is not very, very strong evidence to say that daily fetal movement count or a kick count is useful, but yes, this is something that is so integrated into our practice that we would like to go ahead with it. And this is something that is going to stay in our practice and one of the easiest things to do. So in a meta-analysis that was actually following the FOM trial also did not show any much of a difference, but then of course it was dominated by the FOM trial. So, but still, I would say in our routine practice, we would like to advise daily fetal movement count or a Cardiff's count to 10. So you have to tell the patient at least one particular method by which she should be doing the fetal movement count, and be aware of it. That is something that I would definitely do, and we do continue to do it.
Okay, thank you so much for sharing that experience, Dr. Aparna. So the problem is that there's a wide biologic variation in the normal fetal movement among healthy fetuses, as well as a wide variation in maternal perception of fetal activity. And therefore, we cannot have some standard alarm limits. And therefore, it's so difficult to define what is normal and what is abnormal. The aim of assessment in case of decreased fetal movement is to rule out fetal death. And the next step is to diagnose any fetal compromise or a pregnancy at risk without increasing the number of interventions. So mind fetalness is one term which has come into use now. And it is basically, this is awareness of one's fetal movements, what is right for your baby. And it is associated with health benefits of decreasing cesarean section and fewer children born is small for gestational age. So like Dr. Aparna defined one type of alarm limit that has been set, you have different ways of defining what is right. Then various, Dr. Aparna already told you, there's so much conflicting evidence that we don't know what to advise or whether to use it or not. But if you go into the detail, most of this is useful when the baby is compromised, when you have a very high incidence of FGR as in our population, and it would definitely be useful. So the up-to-date I retrieved last night only, and most of the societies, they still recommend that decreased fetal movement should be evaluated at least within 2 hours, rule out any high risk factors like FGR, or try to determine the cause of the decreased fetal movement, review the symphysiofrontal height, and yes, do the CTG, and then within 24 hours do the biometry of the baby. So that is what should be the right course of action. And the latest guideline from ACOG and the Society for Maternal Fetal Medicine says that the best practice is encouragement of awareness of fetal movement patterns, being attentive to the complaint of reduced fetal movements, addressing the complaint in a systematic way with shared decision making, that is mind fetalness. And Dr. Bharti, would you like to add something to the advice that we say that the woman should be lying in a particular position during throughout her pregnancy? Is it related to the risk of stillbirth?
Yes, ma'am, because going to sleep in supine position is identified as one of the modified risk factor, and it has been found that
what is the reason why?
Because if we look at biologically, it has been seen in MRI in normal, healthy, pregnant women in 3rd trimester, there is a 85% reduction in vena cava diameter and 30% compression of aorta if a woman lie down in supine position. And it has also been found in a meta-analysis that in which I think they have included around 6 case control studies, and they found that in supine position, the risk, that odds risk was 2.6 as compared to the lying on the side. And they found that the population attributable risk in that meta-analysis was 5.8%. That means if every woman starts sleeping on side of their baby, there will be reduction of almost 5.8% of stillbirths. That is the importance of lying down on one side of, on left or right, because it has been seen that right and left, the benefit is almost same, not much difference.
So there's definite, evidence. There is evidence that when the baby is compromised, counting the fetal movements and being aware of the fetal movements is important, and lying on the side is also should be advised to women. So the lady got her ultrasound done, and due to some family issues, she could not come back. Her ultrasound showed an expected fetal weight of 1.78 kg with an AC of 32 weeks, AFI just 5 centimeters, and her Doppler was not done. After 5 days, at 37 weeks, 6 days, she reported to the emergency with absent fetal movements and labor pains. On auscultation, the fetal heart was not recordable. So I quote from Susanna Hopkins, the chair of the International Stillbirth Alliance: "I see the legs, I see the head, I see the heart. The heart should be beating, but it is not." How do you break the news of stillbirth to your patients? What is the right way of doing it, Dr. Bharti?
Basically, this is the most difficult part. Ideally it should be done by the most senior most person who is available in that room. And the most important part in our setup is stop blaming the women. It is our habit, our resident, we also keep, why didn't you come, you were called on the very next day. We start saying it is a human nature. So we all need to improve ourselves, and we all need to understand that. Although there are various protocols, to how to break a bad news. So whatever be the protocol, the principle is same. The first of all, we have to prepare ourselves, how we are, how comfortable we are, how prepared we are, what are, because it is a big setback to a healthcare provider also. It is not as easy, to say ki chalo aapka IUD ho gaya. It takes time, in such case when a woman has come and we did not get the fetal heart on auscultation. So first of all, we have to prepare ourselves. If we are not comfortable, we can take the help of our seniors. Then we have to prepare the patient, because the background of the patient is also very important. It depends on from what status she is. It is not easy just after preparing her, call her attendant and whosoever is with her. Then we have to perform the ultrasound, and during ultrasound just prepare her also, that tell her that your baby is not well and we are not able to locate the fetal heart. Then you give the news, because we have to make her comfortable. And after declaring, then you give some time to the patient with her family. Then you plan her, how to, whether to deliver her or not to deliver.
So thank you so much, Dr. Bharti. It's very important that we prepare ourselves. And I always say that the first casualty of a stillbirth is the doctor himself or herself, because we are the ones who come to know about it first. And preparing ourselves both with the workup of the patient, the knowledge why it happened, and then only we'll be able to counsel her in the correct manner. And there is no absolutely standard way of doing it, but the important principles of communication, that is the spikes model or the ABCD or the breaks model, that we should be training all our residents, all healthcare workers should be knowing that. The lady delivered a stillborn female baby weighing 1.8 kg. The next morning on your rounds, you want to review her workup and ask for the delivery notes. What are the points in history and examination you want to know? And what important details in the delivery notes you are looking for? Dr. Aparna, if you could answer that. Dr. Aparna, what are the points in history and examination which you want to know? So anybody would like to take that question? Important points in history and examination. Dr. Manisha?
Yeah. So basically, we should always start with the history whenever we are going to investigate. So in the history, I would like to know, we know about that she had come and she had decreased fetal movement. But then if it is an FGR, we would like to know the cause of that FGR and whether there are any high risk factor associated or not. So in that, I would like to just find out, you had said that her BMI was also high, probably. So in the clinical examination, her BMI is important. Her height and weight is important. She was whether she was what was her BP, blood pressure, and whether she had any other associated diabetes and all associated, which is associated with hypertension. And then I would like to go into her investigations to find out the reason for her FGR, and also regarding her nutrition, because that would be the most important cause of her FGR. So these are the important things that I would like to know in her history.
So I think Dr. Nandita could add to that. What are the important details in the delivery notes, the placenta and all she would like to know? Dr. Nandita?
Yes. So good evening, everyone. So now such a case needs to be autopsied. That's the first thing. And we do get a lot of information after the autopsy. Now, when we get such a case, it clearly looks like a fetal growth restriction. It seems to be, at least because she's about what week, 37 weeks, I think. And
the gross findings, or when somebody's taking the notes for the delivery, what would you like to know as a pathologist? That should accompany that.
I would like to know her what were the ultrasound findings at what were the last ultrasound, when was it done, and what were the findings, and of course about the socioeconomic status of the lady, and any previous any oligohydramnios or a polyhydramnios present, any other thing to suggest a congenital malformation or an infection or anything like that. So these are the things that I would like to know. And should I continue with my autopsy work?
So we'll come to that just a few moments later.
So, Tamkeen, can I add a few things here?
Yeah, sure, Dr. Manju. Welcome.
So basically, I think the weight of the baby is already given, whether it was macerated, fresh stillbirth, any malformations, any cord, not in the cord, loop of cord around the neck, meconium in the hindwaters, placental weight, all these are the things which I would want to know to be documented at the time of delivery.
Okay, thank you so much. And there was any retroplacental?
Yes,
I think, the priori added that. So what I wanted to emphasize is that a detailed history and examination is the best autopsy, and workup of the, the management of the next pregnancy starts with these details of the previous pregnancy. So the workup revealed the following issues. One important issue was the BMI was 40, GCT was not done at 20 weeks, the report was not available, and blood sugar fasting was 150, that was done later, blood group was O positive, there was FGR at 37 weeks, the weight was 1.7 kg with decreased LICA, and there was no aneuploidy screening done. So these were the issues. So now the next morning on your rounds, you want to assign the cause. Dr. Bharti, can you help us with how will you classify her according to the WHO ICD-PM system of classification?
Yes, ma'am. The first thing I would like to tell everybody that why do we need to classify a stillbirth? You know why? Because we need to have some global system of classification, because whenever we are going to analyze the data of our institute, our hospital, we should be knowing that how many stillbirths we have and what were the complications. That's why we need to classify any classification system. Now, why ICD-PM? Because this ICD-PM is the extension of ICD-10 system of classification system, which has been made specific to perinatal deaths. That is the most important part. And the best part of ICD-PM is it is globally used, and it has got 3 components. Especially in our settings, it tells us about the time of stillbirth. That is very important to know us. Like for this case, we have to know whether it was an antepartum stillbirth or intrapartum stillbirth. Why? Because for each type of timing of stillbirth, we need to have the intervention according to that. If it is an antepartum stillbirth, we need to strengthen the antepartum care of this woman. And if it would have been an intrapartum stillbirth, definitely we require a better intrapartum monitoring. That's why the timing of stillbirth is the most important component of classifying any stillbirth. Now, the next part is, in this classification, we try to assign a single cause for any death, because it's better if we assign single cause, we can act on that. So in our case, our fetus was small. It was a small baby. So it was a fetal growth retardation. That's why we classified this system as A5. It comes under growth related disorder. And the best part of ICD-PM is it captures the maternal fetal diet together, because fetus is totally dependent on mother. If we capture the maternal condition, it will help us to counsel the mother and also improve the outcome of the mother, because we have to intervene somewhere, because fetus has gone right. So whatever modification we can do with the mother. That's why the ICD-PM, we need to classify each stillbirth as per ICD-PM. So in this case, it was a A5, that means antepartum stillbirth with fetal growth retardation, and M4, that is medical disorder to the mother. That was, she was obese, and later she was diagnosed to have diabetes.
So thank you, Dr. Bharti. Dr. Manisha, how do you diagnose FGR?
So FGR is any baby who has not reached its growth potential, genetic growth potential. So by definition, if we go by the maternal fetal medicine ECOG guidelines, it says that whenever a fetal weight or the AC is less than 10 centile, it should be taken. So it's a simple definition. If we go by Delphi consensus, it says that if it is less than third centile, only go by weight or AC. Or if it is between third and 10th centile, then you look at the Dopplers also. And if the Dopplers are abnormal, then you categorize at FGR. But here we have to remember that even a baby who is more than 10th centile can also be an FGR. So for that, we have to see the growth curve. What is the growth curve? So if it's falling, the baby is not maintaining the growth curve, then it can be considered as FGR. And even if a baby is less than 10 centile, then also it can be normal. So that can always happen. But for calculations, we take this 10th centile, and AC and weight both are less than 10 centile, or you can go by Delphi consensus, in which we take Dopplers also.
So thank you so much for simplifying that. The next question is the sensitivity and specificity of different clinical methods for diagnosing FGR. Yeah.
So before we go on to diagnose FGR, we have to be very sure of the dating. That is very important. So the dating in the first visit with whatever it is and whatever methods we have is very important. And with high volume, most of the centers that we have two clinical methods. That is, one is abdominal palpation and another is symphysiofundal height by measuring tape. These two methods are there. Some people say that both methods are almost equal. They have a Cochrane review also indicating this. But in most of the circumstances, we take symphysiofundal height as better. So from anything, it has a wide range of sensitivity from around 20% to around 80-90%, as you can see here. But the specificity is good. The sensitivity ranges, and there are certain factors which can, make the calculation, not very precise. So in this, we have high BMI. So we have to remember that BMI is also a high risk factor for FGR. So if the BMI is high, we can go for other methods like ultrasound. Then we have to ask the patient to empty her bladder when we are examining. It's very important. And then, of course, her parity and her lie, if it is a transverse lie or something, then it becomes difficult. And so these are certain things which makes decreases the sensitivity. But by and large, in a low risk woman, clinical methods have proven to be good, and we cannot say that it is not good. That is the best method that we have as such. So that's it.
So in spite of having, you want to continue? Okay. So it performs best only when measurements are obtained by same clinician using the unmarked side of the tape to reduce bias, isn't it? And then though its sensitivity is between 30 to 86%, but it will be helpful only when you have a very high index of suspicion for FGR, or you are making extra efforts to rule that out. So maybe it has role in a resource poor country like us, but of course it is the sonography which is most important for diagnosing FGR. So is there any role of routine growth scan at 32 weeks to screen for FGR? Dr. Manjupuri.
Thank you, Dr. Tamkin, for that question. Basically, when we look at growth scans, serial growth monitoring by ultrasound, it is an effective intervention as far as high-risk pregnancies are concerned. So we have ample evidence to support that. But universal screening by a serial ultrasound growth scan is investigational. Basically, we are not sure as to how many scans, at what interval, and is it cost effective or not. So most of the societies as of now would say that you monitor the growth with the help of symphysiofundal height, but only taking symphysiofundal height may not be good. You need to plot it. So you need to plot it. Maybe, Intergrowth 21st project does give, the symphysiofundal height at various gestational ages and also gives it in percentiles. So whatever symphysiofundal height at whatever gestation you are measuring, so if you plot it on that, so that will give you the percentile. at which the symphysiofundal height is falling, provided the dates are correct. And based on that, in case you find that it is less than 10th centile, or you find that the centile is falling across the visits, then these are the cases where you can then make use of ultrasounds to look at the growth. This is one way, and the second is, which is also recommended, is that you measure the fundal height, and in case between 18 and 34 weeks, if it is less than 3 centimeters, as far as the period of gestation is concerned, then you opt for ultrasound. But then the fundal height is going to be important only if your patient is, is low risk and is appropriate for, fundal height measurement, meaning thereby there are no multiple pregnancies, there are, the patient is not obese, there are no fibroids which are adding on to the height, there is no hydramnios. So in these kind of cases, the symphysiofundal height measurement or estimation may not be a good idea. So we in our institution had put in this intervention in place in COVID times, because we had we were losing a lot of babies because of less number of visits. So we put in this intervention, and I'll share the data with you. So for 9 months, we did a single ultrasound to monitor the growth at about 36 weeks. So we looked at the Liker, and we looked at the weight, and plotted it on growth 21st that chart. And that was one intervention, and the other intervention was improving the intrapartum monitoring. So these two interventions were put as a bundle, and we found a significant reduction in our stillbirths from 35.7 per thousand to 27.7 per thousand. The difference was statistically significant. So this was what we said, but we no evidence per se to suggest. But I think you can use this intervention, say more in certain circumstances, wherein you feel that the antenatal care is not standard and you have facilities available, then maybe a single ultrasound, anything between 32 and 36 weeks, also may give you a little clue as a screening method, but definitely not, robust evidence to support this.
So thank you so much, Dr. Manisha and Dr. Manjupuri. So basically what we want to emphasize is that FGR is a very important cause of stillbirth. Previous history of FGR is more likely to end, it has more, risk of ending in stillbirth as compared to a previous history of stillbirth. So the past obstetric history and the baby weight of the past baby is also important. And having a very high index of suspicion and careful measurement of the fundal height is important when we are measuring, when we are working up patients in the antenatal clinic, especially important for resource poor setting, because people do have ultrasound available, but they do not know how to use that information. That it has to be a serial ultrasound, not just single ultrasound. They do not know how to do correct biometry, and therefore still measuring the fundal height is an important intervention that can help in reducing. And of course, Dr. Manjupuri, thank you for sharing your data and your small study. I think it could be a starting point for further research.
Dr. Damkin, I would like to emphasize that it is high time that obstetricians they give up that assessment by fundal on palpation. We should definitely take symphysiofundal height and plot it on the graphs. I think that is extremely important. That will make it more objective.
Yes, thank you so much. So the question, why did our son die? Sometimes these things happen. Fatalism about stillbirth in healthcare professionals is universal. There was little recognition of the trauma. This is from the blog by Susanna. Little recognition of the trauma I had suffered, let alone what it might mean for a future pregnancy. And it is one of the most traumatic experiences and with long-lasting psychosocial impact. It needs empathetic and compassionate care, worldwide variation in care, and there's an unmet parental need. Providers are not trained to deal with bereavement, and training of healthcare workers is required for this. So what are the 8 principles of global consensus of bereavement care? We have the senior most person here, Dr. Reva Tripathi. Please comment on that and also share your own experience with us.
Thank you, Dr. Tamkeen. And apart from congratulating you for starting this society and other things, I must highlight that it's great that we've started to talk about bereavement care at all, because this is, apart from the technical aspects of the stillbirths, this is one area which has been grossly and completely neglected, especially by us in India. I mean, I think that we have so many numbers, and so bereavement becomes almost an issue that you leave for nobody to handle. And obviously, we've all been doing it in some kind of way, but it's not been very structured, so it's very subjective. Each one has been doing it in their own way, whatever they think is correct. So there is this elegant publication in last year in February, which was an acronym, which is, the name is very good. It's called RESPECT, which itself is an acronym for Research of Evidence-Based Stillbirth Care Principles to establish global consensus on respectful treatment. So this was actually initially presented in a Royal College meeting and eventually published in the International Journal last year. And though it's probably just like many of these don't really come out with anything very new, but it's in a structured way and it's all encompassing. And because it's put together in one place, so even people who are older like me and experienced maybe in having done this a couple of more times than others, but it's all there together. So first and foremost, they highlight the fact that it must be, everybody must be aware that this problem occurs, including the patient and her family and others. And respectful maternity care is the buzzword these days. It's sad to say that it should be a buzzword. It should be something that should have been present all these years. But anyway, at least is gaining some traction because WHO is talking about it so much now. So in addition to this, we have to empathize with the patient, obviously, because she's got a very shattered situation to deal with. So in addition to these points, which are maybe veering on the social level, you have to be technical also, and you have to go about trying to establish a cause and trying to discuss things with the patient. This, patients have reacted by saying, nobody told us anything. We didn't get an answer. We had many questions. So this type of situation, if we can avoid, if we can discuss it, we give the patient some information and of course, some support, which is possibly something that she desperately needs. And I think we need to also, sometimes we don't really have clear answers. So we need to make a clean breast about it, that we don't really know. And we should actually try to motivate the patient to go in for an autopsy and a placental pathology, because these are also things that cannot be done without consent. And many times patients don't consent. So it becomes our duty to try to coax them into giving a consent by trying to highlight what advantages may accrue from getting these investigations done. And I'm sure that all of us have had experiences when we felt that an autopsy or something should be done, and we really gained because we have got to know of something that was completely unexpected. And this has a gross impact on the future pregnancy, which obviously the patient will be wanting. So there are long-term outcomes, advantages of this bereavement care that can be given. And apart from the fact, when I say long-term advantages, I mean for everybody, at a technical level for the doctors and the caregivers, at an emotional level for the patient, and she hopefully gets some closure on her problem, because many patients say they come to you in the subsequent pregnancy and they say, "Hame nahi pata kya hua tha. हम तो ठीक थे लेकिन बाद में बच्चा तो मरा पैदा हुआ. It's quite a tragedy to actually hear this kind of a complaint. And in addition, of course, this study also reiterates the fact that the staff needs to be trained on this. The caregivers need to be trained how to handle the situation, because many times they are also not able to handle this. So I think this is a good article which everybody should be reading and trying to imbibe the things that they say and ensure that all of it is actually communicated to a lady who's had a stillbirth and a family who's quite shattered by that event. Thank you.
So thank you so much, Dr. Reva. Basically, it should start, like you said, right from breaking the bad news, helping her find answers so that there is proper closure, and then helping her cope with the next pregnancy. All that is part of bereavement care. Dr. Manisha, could you help us answer this question? What investigations will you offer to this couple, and what genetic studies are required in her case?
Yeah. So in this case, especially as in every case, like as you have said, the history is there, but we have to go in for certain investigations. So blood sugar, OGTT and HbA1c, because she had blood sugar deranged also. And as such, also it has to be done in all cases. And then, of course, the torch is controversial, but some people say it can be advised, especially if it is an FGR, it might be a cause of the FGR that has occurred. Apart from that, we can go for APLA-LAC because the antiphospholipid syndrome testing, because she's an FGR, and it can be done. And the fetal-maternal hemorrhage testing by Kleher-Betke has also been suggested, but we don't do it as such. And regarding the genetic studies, so as Dr. Eva has also said, and previously also it has been mentioned, fetal autopsy has to be, always brought forward, especially, and we should start discussing about it in the antenatal period itself and prepare the parents. It is important and we must get it done. So in the autopsy, it is not that only we dissect the babies. So here it is important to understand that we have to examine the baby. So examination externally of the baby and examination of the placenta and cord is very important. Taking the weight, as Dr. Manjupuri ma'am said, it is very important. And then comes taking the photograph. So you have to take a photograph in supine and a lateral. So our residents are all well aware of this, and we take a photograph. So photograph is a very important part. And then after the external examination, you can even go in for X-ray. But for this case, we would like to offer an internal examination also. So if the internal examination is refused, even the external examination in many cases can give us good information, and we must record all findings, whatever is there, and ask the patient to come. So regarding the genetic studies, what samples are to be sent? It's important that we send generally I tell the residents to keep cord blood in heparin, that is green cap vial, and also an EDTA, that is a purple cap vial. So we keep blood in that, and then it can be sent. So if we want to send for karyotyping, we have to send it in green cap vial. And if we want to send for CMA, which is a better test, a microarray, then we have to send it in EDTA. And then if we don't have that cord blood, macerated baby, we might have to send the placenta. So if you want to send the placenta, send it from the cord insertion site. You take a coin-shaped part of full thickness of placenta, and you put it in normal saline, and then it can be sent for CMA. Karyotyping from a POC or a placenta is difficult. So generally you offer CMA or microarray only, and it can be done. And you can even store the DNA if there is a birth defect. So, and what conditions do you offer genetic studies? Either it is an unexplained death, unexplained FGR, or if it is a birth defect, or if it is a hydrops. Generally, these 4 conditions you prefer to send a genetic test.
So thank you very much, Dr. Manisha, because most of the time this is what happens with patients, and we also tend to advise each and every investigation that comes to our mind. And then we end up with something like this. In spite of all investigations, we don't know where the workup is going. So tests should be directed to identify only scientifically proven causes of stillbirth. And now we come to the most important part. What is the role of a perinatal pathologist in the workup of stillbirth, and how do we preserve and send the tissue for histopathology. Dr. Nandita, your wonderful lecture and generous sharing of your case series and images still fresh in my mind. Please help us understand this better.
So the first thing is, thank you very much, Dr. Tamkeen. So the first thing is that we need the baby as soon just as the baby has been delivered, along with the placenta. That's the most important thing. The baby and the placenta should reach us immediately. And if supposing the baby has been delivered during the night, of course, then early morning, we do our autopsies are done 24/7, so they can be just sent immediately. Now, and the form has to be filled in a very good way. We need information. We need the period of gestation. We need the weight of the baby. We need the ultrasound findings. We also need any maternal risk factors. So because we know that basically this case, I'm talking about this case. So this case, of course, is a case of fetal growth restriction. And we can have fetal causes, the maternal causes, the placental causes, and of course, the environment also plays a role here. So we need a complete information which the gynecologist has and send both the things to us. Then what we do is we do a complete external examination, any dysmorphic facies or any meconium in the ears or anything like that, any congenital malformation which is seen grossly, and after that we take photographs, of course, and then we do we know the period of gestation. We also know the weight of the baby that has been sent, and we also do our own weights. So then we do the pathological assessment of the gestational age. We confirm it. So in this, we do the physical measurements and we do the organ, and we also do it by the organ maturation. Now with physical measurements, we do the weight of the body and we do the linear measurements, which correlate better with the period of gestation. In the linear measurements, we do the crown, heel, crown, rump, and the foot length is very, very important. These three are exceedingly important measurements. Then we also do the head, chest, and abdominal measurements, circumference measurements. After that, when we take up all the sections and when the sections come to us, then we have our gross, examination of the brain after we put it in formalin for 10 days. So the weight of the brain is very important. It is about 92 grams at about 24 weeks and about 362 grams at 40 weeks. And and also we can see microscopically because, we have the periventricular germinal matrix, which goes up to the cortex and between 20 to 28 weeks. So it migrates to the cortex. So that is what we see, and we can clearly understand that, now the cells have gone up there, and it is, and by 36 weeks, the germinal matrix gets totally depleted of these cells. And then we have to study the gyral patterns. The gyral patterns are, that gives us very good information on the gestational period between 20 and 36 weeks. Then we do the microscopic examination of the lung. We see whether it is the embryonal, we have the embryonal stage, pseudoglandular stage, the acinar, and the canalicular stage, saccular, and the alveolar stage. So these are the stages, and we can, these are the stages, and we can easily detect, label what period of gestation it is. Just a minute, please, sorry.
So, Dr. Khurana, it's already 9 o'clock.
So after that, we study the kidney. In the kidney, we study the rows of glomeruli, and we can easily judge where we are. So once the period of gestation is ascertained by us, and then as we know, this is a case of fetal growth restriction. So we can have either a symmetrical growth restriction or an asymmetrical. In symmetrical growth restriction, which occurs to the tune of 30%, and asymmetrical occurs to the tune of 70%. So symmetrical growth restriction, the fetal organs are decreased, the weight of the fetal organs are all decreased proportionately. Whereas in asymmetrical, it is not so. And because of redistribution of blood flow in the vital organs, so the brain, heart, and the placenta are normally of normal weight, whereas the abdominal viscera, lungs, kidney, skin, they are of lower weight. Now, just the other day, I had a case in which, the lungs were borderline. It was a case of fetal growth restriction. And why the lungs were borderline was because the kidneys were small. The kidneys were small, so there was oligohydramnios, which led to, this decrease in the weight of the lungs as well. And the baby died in utero. So these are the important things. And then we do the brain-liver ratio. That is also important. We can also do the brain thymus ratio. So if the brain liver ratio is more than 3, it points towards a fetal growth restriction. And if the brain thymus ratio is more than 70, it also points towards that. Now, we see the other microscopic features which take us towards the diagnosis of FHR. That is thymic atrophy, and we can see fat in the adrenal glands. Kidneys are small and they have less number of ranks of glomeruli are decreased. Then there's atrophy of the proximal convoluted tubules, and so hence there is crowding of the glomeruli, and this leads to renal tubular dysgenesis, which can also be proven by cytochemistry. Then the heart is small and can show myocardial necrosis. Lungs are also small to the level of lethal pulmonary hypoplasia in severe IUGR cases. And maybe that is all because of the chronic oligohydramnios, because of secondary to the less decreased weight of the kidneys. Then we have the costochondral junction, we have irregularity of the growth plates. Then in severe IUGR, it leads to the brain growth, and the brain development is less than that expected for the gestation. You can have white matter necrosis with or without axonal mineralization, then which reflects episodes of circulatory instability in days prior to the death. Then we can have hypoxic HIA in the brain, which is very common in cases of FGR. Then placenta. Of course, placenta is a very, very important organ which has to be studied very, very meticulously. In that, we can have chronic villitis, which could be because of infections, or it could be idiopathic, which is called VUE, villitis of unknown etiology. And then there's histiocytic intervillositis, which occurs in malaria. Then we can have a massive perivillous fibrin deposition. Then we can have maternal floor infarction. And so these are the things that we look for in the placenta in cases of which can diagnosis of FGR. So ultimately,
how to send the placenta, the tissue for histopath, that is important.
You can just send it just like that, and we immediately put it in formalin.
So the patient may be delivering at any time during, 24/7, the service may not be available. So how do we preserve if you want to send it for?
If you want to preserve the placenta, put it in formalin, 10% formalin in a big bottle, in a large, just put that in formalin. Or you can even give some cuts to it so that the formalin can seep in better if you want to send it much later. But of course, the baby, you cannot put it in formalin or cut it. So the best is to send it immediately. That's or put it in the refrigerator.
Okay, thank you.
The other thing.
So
this is how we go about with our autopsy cases.
Yeah. So what I wanted to emphasize here is that whatever the cause of stillbirth, whether there are no clinical clues, or there is FGR or hyperintensive disorder, or suspected fetal anomaly, or intrapartum stillbirth, or any other cause, the workup all comes back to fetal autopsy and placental pathology. And this is the latest guideline from ECOG and SMFF. And I remember the importance of autopsy from Dr. Nandita's last lecture, and also from last session by Dr. Ashok Khurana, that many of the anomalies, in spite of having a morphological earlier study, there may be many anomalies which may be developing or detected only later on. So that is the importance of having an autopsy done. So that is what it should be offered to every patient. And it should be a customized approach. And most useful tests are placental pathology, fetal autopsy, genetic testing, and then antiphospholipid antibodies. So in this case, the patient refused the autopsy. Dr. Khurana, if I can interrupt for 1 minute. We are already, I think it's 8 minutes past 9. So, and quite a few slides still there. So,
I think we're doing so well on this. Let's not worry about that. Let's take another 15 minutes and complete things slow and systematically. Yes.
So the panelists, please, it will be appreciated if the answer is fast and quick. Yeah. So the placenta showed, the findings were consistent with reduced uteroplacental or fetoplacental flow. There is no expiration date on grief. I desperately wanted to have a live baby and wanted to get pregnant again. How soon can the couple plan the next pregnancy, Dr. Bharti?
Yes, ma'am. This is the most difficult part to convince our patient. Day-to-day practice, it is very, because every mother whosoever having stillbirth, she wants to conceive very soon. That is what our society wants. But ideally, we should tell the patient at least she should avoid pregnancy for 6 months at least. Ideally, it should be 18 months. But it has been seen that the women who conceive within 6 months, the risk of, the adverse perinatal outcome is high if they conceive very soon. So we should tell each and every woman that at least wait for 6 months, then plan a pregnancy.
So also it will depend upon the cause, isn't it? For example, the cause was diabetes or hypertension. The waiting period would not make much of a difference. But if she underwent a cesarean section, maybe the scar would be stronger. Or if the cause was infection, some of her innate immunity could have taken over by that time. So definitely, as soon as she is mentally prepared and physically prepared, she can plan her next pregnancy. I became pregnant again almost immediately. I was full of joy, but it was short-lived. Why? Because where my first pregnancy was thrilling, secure, and joyful, my second pregnancy was wooden and defenseless. So, Dr. Manjupuri, what prenatal care can we offer to this couple? What is the risk of recurrence in the current pregnancy? Dr. Manjupuri?
Yeah. So thank you, Dr. Tamkeen. Here, actually, other than the prenatal, preconceptional interventions are also important, that all the medical conditions should be optimized before the patient actually conceives. And also in case, she is, a smoker or consuming alcohol or some other drugs, hard drugs, she should be asked to stop that and also optimize her BMI. So I think these are the preconceptional, but once she is conceived, it is good. Now we need to assess a priority risk of recurrence of stillbirth in this patient based on what were the conditions in the index case. So in this case, because she had FGR in the previous pregnancy, so likelihood of stillbirth in this pregnancy is going to be higher because all conditions like abruption, like FGR, these and preeclampsia. So these are the conditions where there you have ischemic placental disorder. So here the risk of recurrence is high. And although there is no, convincing, there's a wide variation in the reports. Most of them say it is about 3 to 4-fold higher. So that means we need to monitor the growth of this fetus very carefully. So that is one thing. And second is, depending upon, the cause of the pregnancy, stillbirth in the previous pregnancy, risk reduction strategies like aspirin for preeclampsia should be put in place. And then if it is GDM, then, early testing for, impaired glucose tolerance in the first trimester, and then again at 24, 28 weeks should be initiated. If she is hypothyroid, then, her thyroid TSH level should be, and T4 level should be monitored. That is another thing. The third thing is, how frequently should be monitored. So we should do ultrasonic monitoring here for fetal growth, and it should be a serial ultrasound monitoring, and it should be initiated. The fetal monitoring should actually be initiated 1 or 2 weeks in advance of when the stillbirth occurred. So this is another intervention which is there. And then the last part is when to deliver. That would be another angle which I can finish here only, that it will depend, it will be individualized. So patients where, the mother is low risk and the fetus is growing well, then there is no need for consensus is that there's no need for early, intervention and delivering the baby earlier than 39 weeks. Yeah. But in case you have a baby which is lagging in growth, or mother has got preeclampsia, or she's got gestational diabetes mellitus, or any other condition, then the timing of delivery would be decided based on that. It is abruptio placentae which creates most problem. If she's had abruption in the past, she's likely to have abruption this time. In that case, we have to kind of do a very careful monitoring and take a call on when to deliver this baby, depending on what gestational age did she have abruption last time.
So thank you, Dr. Manju. I think most important, you cannot start counseling unless you have tried to find a cause. And when you have a definite cause, then you can do a very effective counseling regarding the risk of recurrence. And especially when there's a known cause like SLE or renal disease or diabetes, then you are able to give a good, prediction to the woman. And that is why, and it also helps in closure, like Dr. Reva said. So finding out a cause for that last stillbirth is important for counseling for risk of recurrence. But we should tell her that once a stillbirth has happened, the risk is definitely more. And also she is at risk of preterm delivery and fetal growth restriction in the next pregnancy. Then how will you manage her during the second pregnancy? Dr. Aparna, are you there? Some of that
Yes,
part.
ma'am. Yes, ma'am. I'm there. I'm sorry for the last time. I don't know. I could not unmute myself.
Okay,
So,
sorry for that. Yeah.
Yeah. So, ma'am, I think this question Dr. Manjupuri ma'am has
part of it she has
answered very nicely.
Yeah.
The only thing that I would like to add is, most importantly, I think it's reassurance. That we are looking after you, we are taking care of you, and I think that really, really gives a lot of optimism to the couple. That is something that's very, very important. And apart from the routine antenatal care that we do talk about, and which ma'am has already said, I would say that in terms of pharmacological treatments, aspirin, I would again do a risk assessment for preeclampsia at the time of initial presentation, and I would start aspirin if there is some background risk which I found out on investigations, like for example if APLA has come, or this patient this patient did not have preeclampsia in the last pregnancy, so it's not a very, very strong evidence, but yes, placental factors leading to fetal growth restriction, there is some evidence on aspirin, although it's not very, very strong.
So I would like also to, I would like you to comment on the low molecular use of low molecular weight heparin.
So I would also not like to start the patient on low molecular weight heparin. Heparin has to be started on its own individual merit only if there is antiphospholipid antibody syndrome or some other autoimmune factors where you would want to start it. But otherwise, no, I would not start her on low molecular weight heparin if all her investigations are normal, just to prevent the next stillbirth. So placental factors has been identified, but yet it remains to be seen that whether in this pregnancy an individual risk assessment and should be done standalone, and then we should be starting her on aspirin. So, and again, our management during the first trimester, like last time, maybe it was missed out, a lot of things were missed out. So a dating scan is very, very important to look for development of fetal growth restriction. And then we should be offering the first trimester screening. Again, a low PAPE is an indicator for fetal growth restriction. That would again add that whether we want to add aspirin or not. And if we have done a good double screening, double marker and a combined screening, I would not like to go for a quadruple in the second trimester. I would advise her an anomaly scan at 18 to 20 weeks. And at each gestation, as we would like to reassess the risk for preeclampsia by doing Doppler. So there is actually an algorithm where we keep on assessing for risk of preeclampsia and placental involvement. And then of course, third trimester, 28 weeks onwards, beyond period of viability, we should be offering, growth scans. That is important because of a previous mishap, and fetal surveillance beyond 32 weeks. Between 28 to 32 also, we can start fetal surveillance whenever, and most importantly, we have to be, counseling the patient that, okay, keep a check on your fetal movements, come for routine care. And if all the things are all right, we will plan a delivery and everything will be all right.
So Dr. Reva, how will you perform fetal surveillance in the current pregnancy? Dr. Aparna has, and Dr. Manju have already covered part of it, but just to summarize, how will you perform fetal surveillance in the current pregnancy?
Fetal surveillance is the regular, technically spoken of as NST, biophysical profile, and Doppler studies, if you think that they're indicated. I just would like to say that I think that the clinical should not be left. I do understand that it serves only as a screening tool, but even then, I think that in our country, we cannot afford to neglect the clinical for whatever it may be worth, but I think it is still important. The important point that we need to think apart from this particular case is, when should surveillance start? Now, this is a bit of a difficult question to answer for all patients. For this one, it's clear because probably you would be doing surveillance starting from about 28 weeks but it would depend also on what her mid-trimester ultrasound was. If there is some evidence of a lag of fetal growth already, at the 20-week scan, then you might like to do an earlier scan at about 26 to 28 weeks rather than wait for 32 weeks. So we need to see what kind of case exactly we're handling and then take a call. Of course, NSTs have a problem because this patient also is quite obese, and hopefully she would have corrected her BMI somewhat by the time she got into a second pregnancy, but I don't know how much that correction would have been. And it's good for everybody to know that between 22 to that obesity has problems both with clinical evaluation as well as with ultrasound. It's not, obesity is an indication to follow with ultrasound, no doubt, but itself, there are a lot of errors despite the ultrasound being used because of the obesity. And of course, for the NST also, if you're starting very early, then you have to realize that a large proportion of the traces could be non-reactive simply because the baby is far too preterm. So it's a good idea, of course, as Aparna said, to start at 32 weeks and to continue at least 4 weekly, depending on how the growth is going. And if the growth is not going too well, maybe you could decrease it to 3 weekly. And once you're beyond 36 weeks, then biophysical profile and Doppler would need to be inserted if there is any evidence of lag in the growth, or even if growth is appearing normal, because this is a patient who has got very bad or very bad high BMI. So in her, if you would actually customize the fetal weight, it should be much more. So this would need very close monitoring with Dopplers, with calculation of cerebroplacental ratios and management depending on that.
So what we wanted to emphasize here is that many a times, because the woman is anxious, the lady is anxious, she's asking for the ultrasound. So we have to tell her that according to the cause, she needs the monitoring. Of course, certain cases like abruption, the surveillance will not make a difference. And of course, this increasing the surveillance will also result in false positives and maybe some intervention. So we have to draw a balance somewhere in between. And according to that particular case, we have to decide. But most of the societies, they recommend starting surveillance around 32 weeks or 1 to 2 weeks prior to the previous stillbirth. How would you like to deliver her, Dr. Manju? When would you like to deliver her? Dr. Manju.
Dr. Temkin, I would follow her pregnancy and see how things are. And depending upon how the baby is growing and whether she's developed any kind of problem this time, any associated medical disorder, the timing would be decided according to that. And I'd already, talked about it, that in case it is an unexplained stillbirth last time, and there are no high-risk factors this time. Say there are no maternal complications this time, there are no fetal complications, then 39 weeks would be a good idea to intervene. So that is what is recommended.
Thank you so much. And I would like everybody to remember this important flyer from the the International Stillbirth Alliance, that earlier the practice was to deliver them 1 year prior to the timing of the previous stillbirth. Then it came to around 36 weeks. But now there is no need to deliver, do not deliver her before 39 weeks unless indicated, because the development of the brain is like that. And there are baby is at risk if you deliver the baby earlier. And also later on, the children will be at risk of learning difficulties at the school level. What strategies, now two very important questions from two very senior persons. What strategies for decreasing stillbirth rates would you suggest in the Indian context? And then Dr. Manjupuri, what is a care bundle? What would you include in a stillbirth care bundle? We then just, end with these two important issues. So Dr. Eva, please. Yeah.
Thank you again, Dr. Tamkin.
9:25 almost. Yeah. 9:23. Yeah.
Just 1 minute to say that the
first. Sure. We are just waiting for your,
we should start by making a registry. Let us be clear. I am sure that the large magnitude of numbers is going to be itself an indicator to people that you need to kind of pull up your socks and you need to address this issue of stillbirths. Now, once then we have to look at causes, intrapartum and antepartum. Intrapartum may be a little easier to solve, especially if they are appropriate for gestational age, because then you know that most likely it's due to a management issue of labor. So I think that we could start with that to be training our people, and maybe if we can do things like Lakshya, and if you have one nurse or one midwife allotted to every patient, you know, the ideal kind of way in which labor should be managed. I can't get into any great detail. So that for intrapartum. And then once you talk of antepartum stillbirths, the list is unending. And apart from saying that improving the quality of the antenatal care and being on the lookout for a problem. And of course, if you're in the periphery, if you're in a small center, then please try and identify the patients early and send them to a tertiary level center, or at least be in touch with them so that you know what the red flag signs might be and when some kind of effort needs to be made. So apart from increasing your level of knowledge and increasing your referrals, I think these are all issues that will need to be taken into context. And please, because we're a low income country, don't forget your clinical acumen and don't rely too much on the ultrasounds. I know that they're very important, but despite that, thank you.
So now, Dr. Manjupuri, what is a care bundle, and then what would you include in a stillbirth care bundle?
Right. So, Dr. Tamkin, care bundle is basically a group of interventions which are, given all together, and they all are evidence-based with the purpose of managing a particular kind of condition. So, Dr. Reva had, highlighted a care bundle for prevention of stillbirth. So, in that bundle, I would add one or two more things. One is nutritional, assessment and counseling should also be included in a care bundle for preventing stillbirths. You have malnourishment and you have undernourishment, overnourishment, and malnourishment. So I think that also should be focused on. We are not focusing on that. So that was one part. And the second is when we talk about the care bundle for stillbirth, I understand that you are wanting me to tell the care bundle for management of stillbirth. So first and foremost would be respectful care, both in antenatal, intranatal, and postnatal period. So that is what is most important, because these are special women and we need to look at them and take care of them in a special way. Second is assigning a cause. A total evaluation of stillbirth should definitely be done so that we can assign a cause. And third is dedicated postnatal clinics. Now, it is very important that we should have separate postnatal clinics for these women so that, you have a counselor there, you have, special people to look at, and they review all their records and they counsel them and they do hand-holding, as far as their further pregnancies are concerned. So to my mind, it needs these three components, which are important as far as, care bundle for stillbirth is concerned.
So thank you very much, Dr. Reva and Dr. Manjupuri, for sharing your vision with us. And I request all of you to join the Stillbirth Society of India. It's it only has a life membership of 2,500 rupees. And let's all pledge together to convert every baby shower into a happy mother and a happy baby. Thank you very much. And thank you so much, Dr. Ashok Khurana and Dr. Asha, for having us here. And sorry for overstaying our time limit.
No, I think we've got so much of digested information this evening that we're going to relish it for several more years to come until you keep changing it for us. And I think it's fantastic to have a super specialty society focused like this that can sensitize all of us. We are going to have a little bit more time for our questions, but we need a couple of minutes for our trade partners. If I may request the back end office to see some of the questions. And so we move on to some of the questions. And if I may request the panelists to stay on for just a little while more, to answer some of the questions we've received. I promise you it's not a long list, but a very useful list. And the first question that came in was from Dr. Indu Sharma. We've answered this partially, but if anybody could summarize for us, what is the single best parameter to diagnose fetal growth restriction in unbooked cases? Dr. Parna Sharma, any inputs on that for us?
Yes, sir. So I think sometimes it can be challenging for unbooked cases, but yes, if we do have some form of dating, booking does not mean no ultrasound. There might be a possibility that, they had some ultrasound from previously, but dating from the last menstrual period, take a history of their routine regular cycles or not. So that is number one. Number two is that, sometimes they are able to tell, which month is going on, so that we have the obstetricians, we have another method of looking into, what is the approximate gestation. And yes, if it'll be a bonus if they had a previous ultrasound, preferably sometime in the, at least a late first trimester ultrasound. That would be good. Now, if all of them are present and you have some idea of the gestational age, then yes, the best single parameter would be abdominal circumference to, look at whether there is some growth restriction. But I would say that we will do the complete profile. We will do a biparietal diameter, we'll do the head circumference, we'll do the AC and FL, and we look at the estimated fetal weight. And then once we look at the estimated fetal weight, we have to see whether it is which centile, falling into which centile according to that gestational age. So the only thing that we really need to have is a good estimate of gestational age, and then we can have, some idea of which centile the patient is falling into and whether there is fetal growth restriction or not. Along with that, a Doppler should be done if we are suspecting fetal growth restriction to understand the severity of affection. So booked or unbooked, these things remain the same. The initial assessment will remain the same. And if you are fortunate enough to have time, then we can chart whether the growth pattern in the next 2 weeks is good or not, and whether they're maintaining the trajectory. As we say, if it's a small for gestational age and it is maintaining the trajectory, then it is good enough.
Wonderful. Thank you for those inputs. And of course, the head circumference by itself may not be too bad if you're earlier in pregnancy, but we don't really catch too much of these earlier in pregnancy. My second question that is here in the chat box is on the role of placental maturity in fetal growth restriction, which I presume refers to placental grading. And I can see everybody nodding their head so beautifully from side to side. And Dr. Manisha, would you agree that it is absolutely of no use?
Yeah, so it has been found that it doesn't tell us much, because a very mature placenta might, the fetus would be absolutely normal, and then we would not know much about. But of course, the Dopplers are there, but the imaging of placenta doesn't tell us much.
Yes.
That is the thing.
True. Like I often say, the ugliest of placentas have the finest of function, and the most gorgeous looking placentas can be terribly functional and dysfunctional. And so that we have to be careful about. There is another very interesting question. Is there any subgroup of patients where we have to coax them a little harder to do an autopsy?
I don't know. Is that directed to me?
Yes, please.
I don't know, but I don't think you can really classify any patients as any particular subgroup. It's just that some patients are more difficult to convince. I think they are more perturbed about the whole issue, and there is no category of people, and it's just an individual situation, and you have to take it as it comes and try and coax the family. If you really think, because you don't have any answers and you're looking for something, and the autopsy might be able to provide some answers. So that is the, once we are able to tell them this, that I don't know either, and I'm looking for answers myself, that particular point might be useful to help them to come to a decision to give their consent. But I know that this is a difficult job.
Yes, thank you. And
Can I add?
yes, yes, Manisha.
So
Please.
I feel antenatally, if you are talking to the patient, they are more like, they agree more later on. That's one thing. And the other thing is that we have to be very convincing when we want to, I mean, what do we want from that? Exactly. Like it will tell you about the next pregnancy if we tell, and you can, add that you can get some tissue, which is very important, can be like in kidney diseases. generally I tell them that recurrence risk might differ, or in other such conditions in which there's a high drops. So if you tell them this, and for me, like hardly 10% of them, they disagree. They always agree whenever we are, sound convincing. So that is I think we should be convinced ourselves that it helps. Then only the attendants would be convinced. That's the main thing.
So can I just add, sorry.
Yes, please, go ahead, Dr. Tamkeen. Yeah.
We face a lot of difficulty because there's some misconception because of some religious, issues. They will not agree for autopsy. So I just want to inform that whenever it's an issue of the mother's life or the life or of the next baby, it is allowed in Islam as well, autopsy. So because we did a lot of research on it once we started the society, so that we are able to answer these questions for our patients. So I put this question at various, religious heads, and they have answered that if it is indicated scientifically, then it is allowed.
Thank you. That's a very useful input. What we've also, while we're on the topic of religion, we do understand that the methods of disposal of human remains for stillbirths is quite different even in different communities, which a lot of us are not sensitive about. For instance, in people who are very strict followers of traditional Hinduism, we don't cremate stillbirths. We actually bury them. And the tragedy is that the burial grounds are just completely open to scavengers and dogs. And we really must push this at a social level to understand this. And each one of us must take this on as part of bereavement to explain this to the patient. And in fact, I used to use this information to encourage an autopsy. I said, what would you actually prefer? The mutilation in a scientific, respectful manner, or would you like it to just be disposed of without even contributing? Maybe God has sent us this fetus to try and understand our future for pregnancy. So all this really needs to be put into perspective. And I do look forward to more programs from the Stillbirth Society for these points as well. And then we have some alternatives for patients who do not actually agree to a complete autopsy. We can say do just limited autopsy. And I know Dr. Manisha Kumar is very good at doing these in the delivery rooms. Also, the fact that we can do a clinical photograph to look for dysmorphism, because sometimes that's really, really useful. And in case the fetus really looks odd, we can do an X-ray infantogram. And these things do contribute in their own little way to the contribution of anomalies for this particular situation. So thank you so much for that input. There is one more question of importance, and this is from Dr. Jayaraman Nambiar, and he wants to know about the role of ensuring calcium to prevent preeclampsia, which of course then is related to stillbirth. So any inputs on the best way to make up for our calcium and when should we do this?
Yeah, so basically, Dr. Ashok, this is a recommended intervention in patients who are likely to be having low calcium levels, not for healthy, patients where the diet is already replete.
Yes.
So it is a good intervention, but only for them.
In a higher dose,
Yeah, 2 grams. Yeah.
Not easy to take 2 grams.
I had my own thesis on this. I still have a reference in the Williams textbook on effect of calcium supplementation on prevention of preeclampsia. Yeah.
Yes.
So recommended those populations where there is deficiency.
Yes, and in fact, I'm so amused that the actual citations of Dr. Manju Puri's original work is far more in the last 10 years than when she first produced this. And every single FIGO comment that comes on it always includes that comment. And we have to be truly proud of it. Yes, I know we always get appreciated later. Then there's a very interesting question in patients who do not check, who do not test high risk for preeclampsia at the 12-week window. On the basis of an abnormal uterine artery Doppler, should we intervene in any sort of way to improve outcomes? And anybody on the panel? That means uterine artery Doppler is abnormal, but the total risk for preeclampsia is low risk.
So can I take this question?
Yes, please. Yes.
So we do understand that the reason why we have made a risk calculation system is that it improves the positive predictive value. Now, if we only take uterine artery Doppler, the positive predictive value is between 30 to 40%. So this is something that, we need to understand. And, overall, if you look at the past history and all of those things that remain important, but yes, if the overall risk is low, then we understand that positive predictive value is low. And even if, we want to give aspirin, we need to really counsel the patient and say that, okay, we don't know how much this aspirin is going to work. So in an ideal setting, no, but in a real world, of course, individual decision needs to be taken. And as I mentioned earlier, keep calculating the risk at each time. It is not just the first trimester, it needs to be continued into the second trimester and the third trimester to understand, what is the risk and, how frequently maybe you would need a more frequent monitoring. So this is something that needs to be done, but only on the uterine artery Doppler may not be a very good idea. But yes, this is something that needs to be kept in the surveillance, that, okay, there is a chance of development. Let us keep you under surveillance and have an, early management sort of things. That is more important.
Excellent. Thank you for that input. The other question is related, of course, to the development of new biomarkers. So what is the status of biomarkers at the moment for general surveillance of high-risk pregnancies, but specifically for stillbirths? Do they have any proven roles so far?
Yeah, so can I take this? Like,
Yes,
we have recently concluded this IIS with Roche, and in which we had done the biomarkers at 20 weeks, 28 weeks, and 34 weeks. So what we have found, that it was a very interesting finding, that all women who had very high levels at 20 weeks, either they had IUDs or they had neonatal admissions, which was increased, and neonatal deaths. So all of them, like, they were only 10% who had very high levels and at 20 weeks. So by 30 weeks or 32 weeks, all of them had some of the other problems. And only 2 of them who didn't had this problem, they had decreased level at 28 weeks. So this was a very interesting findings. And especially I would like to say that SFLT and PLGF, the ratio is very important in the early trimester with respect to fetus. And later on, like at 28 weeks, we found that all those who had high levels at 28 weeks had, 70% of them had preeclampsia at around 32, 34 weeks. So the sensitivity and specificity was very high in early weeks, and that too causing fetal abnormal, fetal stillbirth or neonatal admissions in nursery. So these were very important findings that we had, and these were high-risk pregnancies that we had taken. So
And,
they definitely have some role.
Yes, of course. And I'm sure we will ultimately evolve one nice little chip that we put onto the maternal abdomen, and that tells me everything that's going to go wrong, and there's going to be a stillbirth or there's going to be eclampsia, and I can handle this. I do hope I see it in my lifetime, and that I don't have to wait too long for that wonderful chip that will tell us everything. But in the meanwhile, 2 last questions. One is from Dr. Geeta Devi, and she wants to know, do we have to monitor platelets and coagulation profile during expectant management after stillbirth? Is there any recent evidence? She feels that practically we don't see such derangements in clinical practice, and no such derangements are seen in expectant management of single fetal demise in twins. But are there any guidelines on monitoring platelets and coagulation profile during expectant management after stillbirth?
Sir, I would like to take this.
Yes, please.
Yes, sir. What guidelines available? They say that we should do it bi-weekly, ideally, but practically we don't see it much. But usually we are doing it 8 to 10 days, but we do it. But in twins, we don't see it commonly, so we don't monitor. But in singleton pregnancy after IUD, we do monitor, and even the recommendations are there.
So it depends also on the cause of the stillbirth that was there, and also it's not, most of the time it is a chronic type of DIC that is happening in a stillbirth. So it will take at least 3 weeks to develop, and by that time you will have already delivered the woman.
Yeah, absolutely. One final last question, and I love this question. It's absolutely delicious.
Yeah, I love that question.
So it's about cord around the neck and its association or causative association with stillbirth, and our enthusiasm for cesarean section and cord around the neck, etc., etc. Could someone please, or all of you please, put this into perspective? I know that most of us tuned in this evening already know the answer, but this is going to go onto YouTube very shortly, and we'd like other people to benefit from the wisdom of true wisdom. And if you could tell us, what do we do about this cord around the neck, and how do we make people
Can
understand?
anybody, can anybody, would anybody, one of the panelists like to answer that?
Go ahead, Dr. Temkin, you can start.
It's so common
Everybody would
knowledge.
like to answer this, but I think, ma'am, you should go ahead.
Patients are told that they need a cesarean section just because the cord around the neck is there. So I always tell them that it is normally there in 25% of the cases. Just like it got entangled, it can untangle itself as well with time sometimes, or it may not entangle. Only it needs closer monitoring, that's all. It's not an indication of cesarean section. And in relation to stillbirth, even when you find that there is a true knot or there is a cord around the neck, please do not attribute or assume that this is the cause of the stillbirth. You have to have findings in the placenta, infarction, thrombosis, and then only you can say that this was related to the this cord around the neck or the true knot was related to the stillbirth. And otherwise look for another cause, but you will miss something and it may recur in the next pregnancy. So anybody else would like to add to it?
I would not spend so much of time. I would tell them not to pay any heed to it. And I would request the ultrasoundologist not to comment about it. So that would be my suggestion. Yeah. So it should not be commented and it should not be commented at all. It is not a desirable element which has to be as a part of the report. So that is my take on that.
Yes. Unfortunately, the battle that we constantly have is that if on the off chance there is an adverse event, they said, well, you know, it was missed. And then no amount of coaxing in any court of law seems to help. So it's got a bad habit has got reinforced. But the fact remains that the more we publicize this fact from scientific forums, the more people will understand that it is a tragic situation that has evolved through a series of wrongs and lies. And we must put an end to this sort of a belief. But I really want every one of us on the panel today to give a comment on this so that it really gets reinforced.
So I would also like to add is that, you know, even most of the reporting societies, reporting templates of all the ultrasound, like ISWOG templates, or, you know, none of them, they actually ask to comment on cord around neck.
That's
so, right. You know, even that is so an important evidence to say that, you know, we should not look into it.
True. And, you know, there is this excuse that we receive sometimes that, look, this is very precious pregnancy, it's IVF, and she's 49.5 years old. But that is not evidence. That is not normal practice. That is an excuse, and that is not science. Would everyone agree with me on that?
100%.
Yeah.
And some last inputs from Dr. Neelam Agarwal before we wind up and hand over to our hosts.
Yeah. Thank you, Dr. Khurana, for giving us this opportunity. And it was a wonderful, wonderful panel discussion. Everybody has prepared so well. And I think messages have been clearly conveyed across. And I think this should help even the general practitioners, means general gynecologists, not only the specialists. This will definitely help in sensitizing people about stillbirth and managing the stillbirth and in the subsequent pregnancy care and care before the next pregnancy, what all is to be done. I think clear messages have been given. Thank you so much. Thank you, everyone.
Thank you indeed. And so back to our hosts, Dr. Asha Jain and Dr. Tabassum Dalla for the final notes.
Thank you, sir. What a wonderful webinar we had today. It was absolute pleasure to have all the SFM stars today with us again. After such a long time. So we really enjoyed it a lot. Thank you, Khurana sir. I would also like to thank Dr. Asha Jain madam. And my sincere thanks to our esteemed speaker today, Dr. Neelam Agarwal, for sensitizing us to deal better with our stillbirths. Even we need tender loving care when we have stillbirths, our patients have stillbirth. I would also like to thank all our esteemed panelists, Dr. Reva Tripathi, Dr. Manju Puri, Dr. Manisha Kumar, Dr. Aparna Sharma, Dr. Bharti Sharma, and Dr. Nandita Kakkar. Thank you, each and every one of you. I would also like to thank our trade partners, LifeCell and GE. Thank you so much. Thanks each and every one of you, all the delegates who are present today. Have a great evening. Thank you.
Thank you. Thank you very much.
Thank you so much. Thank you.
Good night.
Thank you.
Thank
Good night.
you. Thank you.
Dr. Ashok, yeah. And to all the people who logged in, there were 150 people at the start and 131 at the end. The last question that was answered.
Yes.
So thank you so
Thank you,
much.
Tamkin madam. Thanks a lot.
Thank you.
Thank you.
Thank you.
So much.
Goodbye. Night.
Goodbye.